Hi, welcome to the World Thrombosis Day 2021 webinar, co-hosted today by the International Society on Thrombosis and Hemostasis, ISTH, and by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. Today's webinar takes a deeper look into the clotting risks during hospitalization, with special presentations on general thromboprophylaxis, special cases, and thromboprophylaxis and cancer. I'm Dr. Claire McClintock, and I'm delighted to be with you from New Zealand today as our moderator. I serve as the Vice Chair of the World Thrombosis Day Steering Committee, and I'm former President of ISTH. I'm a clinical and laboratory hematologist specialising in obstetric medicine in Auckland, New Zealand. Tomorrow, or today for us in New Zealand, is World Thrombosis Day, and we're excited to have you with us at this webinar today as we kick off celebrations to recognise World Thrombosis Day. World Thrombosis Day is a global movement recognised each year on October 13th that focuses attention on the overlooked and often misunderstood condition of thrombosis, which includes venous thromboembolism, or VTE. For today's webinar, we have brought together leading thrombosis experts from around the world to bring latest information and research to you. Our presenters today include Professor Beverly Hunt, Professor Alex Paropoulos, and Professor Alok Khurana. And I'll introduce each of them prior to their presentations, respectively. Now, just before we get started, what I'd quite like to do is to learn a little bit more about who we have on today's webinar. We have two poll questions that you'll see in the polling portion of the webinar platform. So if you'd please indulge me to answer the first poll question: which region of the world are you from? And moving to the second poll question: if you are a healthcare provider, do patients admitted to your hospital undergo VTE risk assessment? Thank you for sharing your responses with us. I'm sure our poll will indicate that we have a very diverse audience with us. And we're representing many, many regions around the world. So I'm very glad to have you here. So before we get started with today's presentations, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We'd like today's webinar to be as interactive as possible, and as such, we would encourage you to submit questions using the Q&A option available. We'll monitor the questions and address as many as possible as we can during the webinar and at the conclusion of the webinar. And then also, once the webinar is complete, we'll try and address as many questions as possible. Please note that today's webinar will be recorded, and we'll share a copy of the recording via email following the conclusion of the webinar. We welcome you to share this with your colleagues. So let's get started. I'm pleased to introduce our first speaker, Professor Alex Paropoulos, who will be discussing the latest thromboprophylaxis on medical patients. Professor Paropoulos is a professor of medicine in the Donald and Barbara Zucker School of Medicine at Hofstra Northwell in New York City, USA. He is System Director of Anticoagulation and Clinical Practice, and Clinical Thrombosis Services at Northwell Health, and a professor at the Feinstein Institutes for Medical Research. Over to you, Professor Paropoulos.
Thank you. Thank you very much, Professor McClintock, for that nice introduction. I'd also like to thank the ISTH and the CDC for co-hosting this important webinar. And also, it's been really a privilege of mine to have been on the steering committee for World Thrombosis Day all these years. So I'll be discussing a topic which has really captured my academic interest for the last 2 decades or so, from hospitalized medical patients. And these are my disclosures. And by way of introduction, I think many of us realize that hospitalized medical patients, including those with pneumonia and sepsis, are a heterogeneous group at overall moderate risk of venous thromboembolism, or VTE. That risk is reduced by about 50% or so with the use of in-hospital parenteral thromboprophylactic agents, with special considerations for stroke and critical patients. VT risk models in these patient populations have now undergone extensive validation, and a subset of these patients, about 25%, are at high risk of thrombosis post-discharge, where the risk of major and fatal thromboembolism is reduced by up to 30% with the use of direct oral discharge. And lastly, hospitalized COVID-19 patients represent a subset of medically ill patients at very high thrombotic risk, and many have breakthrough thrombotic events despite standard thromboprophylaxis. Now, we now have a very good sense of what are some of the key VTE risk factors in hospitalized medical patients: a prior history of VTE, acute infection, and especially COVID-19 as a novel disease state within a subgroup of patients with acute infection represents patients at very high thrombotic risk, as we'll see. Malignancy, advanced age, the presence of cardiopulmonary disease, stroke, and mobility and ICU stay all represent high VTE risk factors. More recently, elevated D-dimers are also predictive of patients at high risk of thrombosis and are very relevant, as we shall see, in the COVID era. Now, in the last 10 years or so, there have been multiple VT risk models in medical patients that have been developed, of which the PATO and IMPROVE have undergone the most extensive external validation. Both models include clinical risk factors, which are weighted and scored from 1 to 3 points, and depending on what score threshold is achieved, can identify patients at low, moderate, or high VTE risk. More recently, the IMPROVE tool also incorporated elevated D-dimers to improve model discrimination, and again, as we'll see, important in the COVID era. Now, in medical patients, we have data over the last almost 3 decades that tells us the use of parenteral anticoagulants compared with no parenteral anticoagulants in hospital settings can lead to about a 40% reduction in pulmonary embolism, with absolute effects of about 4 fewer PEs per 1,000 patients. However, there is no reduction in mortality with the use of thromboprophylaxis, and this does come with a potential increase in major bleeding. For stroke patients, the recently published clot trials also taught us that graduate compression stockings are not effective, but the use of intermittent pneumatic compression is effective to reduce proximal DVT, and with a trend towards a reduction in 30-day mortality, although there is an increased risk of skin breaks. And of course, these have to be administered correctly to be effective. Critically ill medical patients are a special subgroup of hospitalized medical patients at very high thrombotic risk, but also with potential for bleeding diatheses. Overall, there are few and small clinical studies. Ultrasound screening should not be routinely performed, and the benefits of prophylaxis are potentially greater than in non-critically ill patients. The differences between the heparins and mechanical prophylaxis regarding efficacy is quite small, but low liquid heparin once daily likely is most convenient and probably most cost-effective. The guidelines suggest the use of either low liquid heparin or unfractured heparin prophylaxis, and of course we must be wary of dosing patients with hepatic or renal failure. Lastly, in a subset of medically ill patients, we now have consistent longitudinal data that the risk of VT extends well beyond hospitalization in the post-discharge period, rising sharply in the first 3 weeks post-discharge and plateauing at about 4 to 6 weeks. Indeed, in high-risk elderly medical patients, the vast majority of VT events, about 80%, occur in this post-discharge period. Extended thromboprophylaxis using either low liquid heparin or DOACs produces an about 40% reduction in symptomatic VT and VT-related death in medically ill patients, but does come at a price of a 2-fold increased risk in major bleeding. So importantly, we have to learn to select patients at high VTE and relatively low bleed risk that would, in theory, benefit from a strategy of extended thromboprophylaxis. Well, this has been done. Recent reports suggest that the IMPROVE tool, using a cutoff of 4 and elevated D-dimers, is able to predict a nearly 3-fold higher VT risk group of medically ill patients that would benefit significantly from extended thromboprophylaxis. Also, in terms of bleeding, A recent report also suggested that if we remove 5 key bleed risk factors in this population, namely active cancer, receipt of dual antiplatelet therapy, any bleeding within 3 months prior to hospitalization, the presence of active gastroduodenal ulcer, and bronchiectasis or pulmonary cavitation, we exclude about 20% of hospitalized medical patients. And in the remaining 80% of patients, what we see is a reduction in major bleeding by about 50%, both in the in-hospital and post-discharge phase, and importantly, an appreciable reduction in fatal bleeding. So with respect to medical thromboprophylaxis, we're entering, ladies and gentlemen, what I like to call a new paradigm in medical patient thromboprophylaxis, that of an individualized, patient-centric, and risk-adapted approach. And for those health systems with, again, sophisticated informatics, the use of, again, a decision support system using electronic health record interoperability. The acute hospitalization period in this population still represents the highest risk period, but only about 50 to 65% of your medically ill patients are at or high VT risk during this period. We should still formalize VT risk assessment at admission, but move away from a group-based or universal thromboprophylactic strategy and move towards an individualized VTE, a risk model, using either key high-risk individual VT risk factors, or better yet, the use of validated VT risk models such as IMPROVE and Padua. And depending on what threshold risk is scored, again, give patients appropriate thromboprophylaxis with either unfractured heparin, low molecular heparin, the pentasaccharide fondaparinux, or in the United States, the DOAC rivaroxaban. Secondly, the immediate post-hospital discharge period also represents a high-risk period for about a quarter of hospitalized medically ill patients. And again, we should move towards a strategy of formalizing VT risk assessment at discharge, especially in those health systems such as those in North America with very compressed hospital lengths of stay. And depending on whether individualized risk factors are seen that predict a high risk of thrombosis, advanced age, history of VT or cancer, or better yet, using validated scores such as the IMPROVE tool or elevated D-dimers, again, give receipt of thromboprophylaxis with the DOAC rivaroxaban being approved for this use. Now, I think we would be very amiss with respect to thromboprophylaxis of hospitalized medical patients if we didn't include the COVID-19 population as a subset of medically ill patients. Indeed, early on in the pandemic, multiple research groups in thrombosis, including ours, saw some very unusual characteristics of thrombotic complications, both in hospitalized, but especially in critically ill COVID-19 patients. Firstly, was simply the high prevalence of thrombotic complications in these patient populations, with a tendency towards increased rates of venous thromboembolism, and especially pulmonary embolism, which is less subject to bias, with a threefold higher risk compared to historical matched controls. Secondly, was the very unusual nature of thrombosis in COVID-19 patients, with evidence from CT pulmonary angiography, pathological slides, and other studies suggesting in situ pulmonary microthrombi and thrombi and megakaryocytic deposition, all leading to now a well-described phenomenon of thromboinflammation. But to a clinician, the most worrisome aspect of COVID coagulopathy was the phenomenon of breakthrough thrombosis despite standard thromboprophylaxis. And towards this end, multiple US and international cardiovascular and anti-thrombotic societies produced guidance statements advocating for a universal thromboprophylactic strategy using standard doses of heparin for both ward and ICU patients hospitalized with COVID-19, with a minority of these documents also advocating for post-discharge thromboprophylaxis in patients with high-risk features. But because of the phenomenon of breakthrough thrombosis, over 20 global randomized trials were launched early in the pandemic to see if there was further advantage in using escalated or even treatment dose heparin versus standard of care heparin in hospitalized COVID-19 patients. The study designs, for the most part, represented open-label, multi-center designs. The populations included both non-ICU ward patients as well as ICU patients. The intervention, for the most part, included therapeutic dose low molecular heparin. The control group included institutional standard of care heparin, and the primary outcome consisted either of mortality or freedom from organ support or combinations of the above and thrombotic outcomes. And conceptually, there were two clinical trial designs studying this issue. the use of heparin as an add-on treatment approach in potentially reducing the severity and morbidity of COVID-19 pneumonia, or the use of heparin in a classic antithrombotic clinical trial design to see if an established agent has further potential in reducing macrovessel complications as well as mortality, presumably from thrombosis. Now, this slide gives us a summary of the published experience comparing either escalated or therapeutic dose heparin versus standard of care thromboprophylaxis in hospitalized COVID-19 patients. The Inspiration trial and the ICU population showed no benefits of intermediate dose heparins versus standard dose heparins. The Action trial, which included both ICU and ward patients, also showed no advantages of the DOAC rivaroxaban started in the inpatient setting and continued for up to 30 days post-discharge versus standard dose heparins. And lastly, the multi-platform trials in ICU populations further showed no benefit of therapeutic dose heparins versus standard or intermediate dose heparins in improving the primary outcome. However, the identical trial, the sister trial of the multi-platform trials in ward patients, saw a very different results in this population. Indeed, there were clear advantages of using therapeutic dose heparins over standard and intermediate dose heparins in improving organ support-free days and also potentially mortality from such in the ward population, with what appeared to be a greater absolute benefit in those patients with elevated D-dimers. And lastly, the recently published HEP-COVID trial that was conducted both in ICU and ward patients and selected a very high-risk population of COVID-19 patients using a strategy of elevated D-dimers greater than 4 times the upper limit of normal. So clear advantages of therapeutic dose low liquid heparin versus standard and intermediate dose heparin in reducing the primary outcome of major thromboembolism and all-cause mortality. And much like the results of the multi-platform trials, almost all the treatment effects were seen in the non-ICU populations and essentially none in the ICU populations. Now, some of the mechanisms of the dampening of COVID-19 coagulopathy by heparins, including low liquid heparins, was as follows. In addition to the well-known effects in preventing the incidence of macrovessel thromboembolic disease, heparins also have potential for pleiotropic effects in this population, including anti-inflammatory, immunomodulatory, and potentially antiviral effects as well. So what have we learned from the randomized trial data of anticoagulation in COVID-19 patients? Well, number one, the potential for pleiotropic or anti-inflammatory effects of heparins are only helpful early in the disease course, such as the non-ICU or ward setting, before a hyperinflammatory state and cytokine storm sets in. In critically ill patients, it's simply too late to engender a treatment effect. The multi-platform trials taught us that heparins are possibly beneficial in reducing microvascular thrombosis and intravascular, especially as it pertains to improvement in end organ failure syndromes such as ARDS, but more research is needed in this topic. And data from the beta D dimers are an exquisite biomarker for poor outcomes in non-ICU populations. Select a population with potential for modifiable disease using a just-in-time paradigm for heparin. And lastly, one should use optimal, i.e. therapeutic doses of heparins for thromboprophylaxis in these very thrombotic risk populations. Secondly, small molecule DOACs do not appear to have the same pleiotropic or anti-inflammatory effects as the heparins and are likely inferior to them in the inpatient settings. And of course, one must think about the population studied and the trial designs. In my view, a traditional antithrombotic clinical trial design has the best chance of success using an established agent and modified. There should be better clarity once a WHO prospective meta-analysis as well as a Bayesian network meta-analysis have been completed in these populations. Now, lastly, I'd like to end with the, again, rates of thrombosis and death in the post-discharge setting of COVID-19 inpatients, an area that was controversial until recently. Earlier retrospective data suggested a lower than expected rate of thrombosis and death, but our group recently published the large prospective CORE-19 registry of about 5,000 hospitalized COVID-19 patients. We saw a higher than expected all-cause mortality rate of 4.8% and major thromboembolism rate of 3.2% in the 90 days post-hospital discharge. Some of the key predictors of post-discharge thrombosis and death included advanced age, the presence of cardiovascular risk factors and chronic kidney disease and ICU stay, and also an elevated improved score of 4 or more. And in multivariate analysis, receipt of post-discharge extended thromboprophylaxis decreased thrombosis and all-cause mortality by 46%. These intriguing data were later confirmed in the recently presented Mitchell trial of post-discharge thromboprophylaxis in COVID-19 patients. The trial selected a high-risk COVID inpatient population using an elevated improved score and elevated D-dimers. All patients had to have standard inpatient parenteral thromboprophylaxis, and the trial randomized patients at discharge to either rivaroxaban 10 milligrams up to 30 days or no anticoagulation, and found, I think, an impressive 6% absolute risk reduction or 67% relative risk reduction of the composite primary outcome of major thromboembolism and cardiovascular death. So to conclude, what are some of the future antithrombotic strategies in hospitalized COVID-19 patients? I think we have some exciting new data, both from the multi-platform trials, as well as recently from HepCOVID, that therapeutic dose heparin, especially low liquid heparin, because of more predictable pharmacokinetic profiles, should be considered the new standard of care for thromboprophylaxis in these patient populations, especially using a D-dimer-based strategy, in my opinion. For the critically ill population, the same strategy not only produces no treatment effects, but potential harms. And for this population, we really have to think of out-of-the-box approaches, including the use of fibrinolytic therapies, potentially antithrombin, thrombomodulin, activated protein C, contact pathway activated inhibitors, tissue factor 7A pathway inhibitors, or multimodal strategies. And lastly, in the post-discharge setting, I think some early data from Michelle clearly points to the fact that prophylactic dose DOAC should be considered the new standard of care in these patients with high-risk features, including elevated improved scores or elevated D-dimers. With this, I'd like to thank you all, and again, remind us all that 13th of October is World Thrombosis Day, and thrombosis, know the risk and reduce the burden. Thank you very much.
Thank you so much, Professor Paropoulos, for a wonderful presentation and a wonderful summary of the up-to-date data relating to not only hospitalized patients, but in particular COVID patients. So I'd like now to introduce our next speaker, who is Professor Alok Khurana. Professor Khurana joins us from the United States, where he is Professor of Medicine at the Cleveland Clinic Lerner College of Medicine, Case Western Reserve University. We're very glad to have you with us today, Professor Khurana, and to share more about thromboprophylaxis and cancer. Over to you.
Great, thank you, Professor McClintock, and thank you to the ISTH, to the CDC and World Thrombosis Day for the invitation to discuss thromboprophylaxis as it applies to the very special population of people with cancer. These are my disclosures. I'll leave them up for a second. Before I even launch into thromboprophylaxis, I think it's important to understand why this is an important issue in people with cancer. Here's some very new data from Mulder and colleagues looking at about nearly half a million Danish cancer patients and comparing with 1.5 million a comparison cohort of individuals without cancer. And what they found in this study published in Blood just this year was that compared to the general population, the 12-month risk of VTE was substantially increased in people with cancer with a cumulative incidence of about 3%, which has a ratio of 9. And in people with cancer who were on chemotherapy or targeted therapy, so basically any systemic treatment for cancer, that incidence was even higher at 5.3%, and the hazard ratio compared to the non-cancer population was 20. So it was a real substantial increase compared to non-cancer patients. And not only that, there was an increased trend. So this incidence rate actually reflected the overall rate between 1997 and 2017. But if you look at more recent years, there was a 3-fold increase across all cancer patients and a 6-fold increase in rates of VTE across patients receiving chemotherapy. And you can see that here in the picture on the left from the same trial, rates between 1997 and 2017 for the non-cancer comparison cohort have stayed relatively stable with maybe a slight uptick, especially in the 2000 era. But for the cancer population, as you can see in red, there has been a substantial increase starting from 97 and extending all the way through 2017. We're now in 2021, and there's no suggestion that this increase rate has decreased in any fashion. And so likely the rates currently are even substantially greater. This was also shown in a study specifically of hospitalized cancer patients, shown on the right by Lyman and colleagues, where they looked at rates of VTE across all cancer patients that were hospitalized, and then specifically in cancer patients on chemotherapy. And as you can see, for whether we looked at PE rates, shown in the line in the red on the bottom, VTE rates in or DVT without PE, VTE for all patients, and then VTE for patients on chemotherapy, which is this purple line all the way on the top. Rates per hospitalization were quite substantial. You just heard from Professor Paropoulos on the rates without COVID and with sort of generally ill medical patients. You can see here 8% per hospitalization in VTE patients on chemotherapy represents a substantial increase compared to the non-cancer population, and rivaling many other conditions for at high risk for VTE. It's also important to note that the risk of VTE has gone up even as treatments for cancer have changed and largely have become more successful. And so previously many felt that perhaps the risk of VTE was associated with the type of cancer or the treatment of cancer being mostly chemotherapy, and so possibly related to chemotherapy. But here's an example of melanoma patients. Our group just published these data in an immunotherapy journal. Melanoma is very unique because chemotherapy actually doesn't work in this population. And so it's a reflection of sort of the pure impact of immunotherapy on the risk of melanoma. Melanoma is also not a cancer that's well known to be associated with the risk of VTE. But here you see cancer patients with a melanoma diagnosis starting starting immune checkpoint inhibitor therapy, which is a newer way of treating cancer patients. And rates of VTE at 6 months with single immunotherapy agent were about 5%, approaching nearly 10% at 12 months. And if you're getting a double regimens, so 2 immunotherapy drugs instead of 1, 6-month rate was about 17%, approaching 21% at 12 months. In addition, despite this being immunotherapy, which is very successful in treating melanoma, overall survival seemed to be strongly linked with the occurrence of VTE. So if you were a melanoma patient on immune checkpoint inhibitor therapy and you did not get thromboembolism, your survival at 2 years was 71%. But if you got thromboembolism, your survival at 2 years was only 51%. That's a 20% absolute decrease in 2-year survival, which is very, very meaningful. And this p-value is highly statistically significant. But I think more than that, it's highly clinically significant. And I think it's important to keep this in mind as we evaluate the impact of thromboembolism on people with cancer. So why is cancer-associated thrombosis highly consequential for people with cancer? Number one, as I already discussed, it's highly prevalent. Venous thromboembolism rates are, vary widely, but are raised in the cancer population and continue to rise, as we saw. I didn't show arterial events, but that's shown in this little graph here. Arterial events are also high after diagnosis of VTE, approaching about 5% at 6 months, which includes a 2% rate of a 2% rate of stroke and a 3% rate of MI. Both venous and arterial events account for about 9% of deaths, so they're directly associated with mortality. Nearly 1 in 10 deaths in people with cancer occurs from either a pulmonary embolism or an arterial event. And they're also indirectly associated with mortality. I showed you data with melanoma and immunotherapy. If you consider all systemic therapy, VT is associated with a nearly 5-fold increase, hazard ratio of 4.8. If you're a cancer patient and you develop a VTE, the chance of dying within 120 days of starting chemotherapy is almost 5-fold higher, according to this paper by Kuder and colleagues, than matched cancer patients with the same age, same type of cancer, same stage of cancer, and receiving the same chemotherapy, but they did not get VTE. And so an indirect association with mortality. And then it's not just mortality, there's also consequences, hospitalization being one of the most important ones. There's a 3-fold increase in all-cause hospitalization. And if you're in the hospital, the chance that you'll stay longer in the hospital is greater if you have a cancer patient with VTE than a cancer patient without VTE, 10 days versus 3 days in the US. And of course, any hospitalization emergency room visit can interrupt cancer therapy, which is obviously crucial to keeping people alive and increasing cure rates. So substantial and very meaningful, clinically meaningful impact on people with cancer. So hopefully you agree with me that given all these important clinical consequences, prevention is important in the cancer population. But even the road to prevention in this population is complicated. A common sort of number that's thrown around is that 1 in 5 cancer patients will get a blood clot. And if we accept that number, then that still means that 4 out of 5 cancer patients will not get a blood clot. And cancer patients are also at increased risk of bleeding. And so how do we target people appropriately so that the high-risk patients are identified and offered prophylaxis and low-risk patients are not? Because the truth is that risk of VTE in cancer patients is highly variable between cancer subpopulations and even across time in the same cancer patient. Here you see very widely variable rates between different types of cancers. Pancreas and brain tumors have some of the highest rates. Breast cancer, prostate cancer have some of the lowest rates. And as time elapses from the diagnosis of cancer, you see that rates are very high initially, and then they drop over time. And so identifying high-risk patients is really crucial to implementing appropriate prophylaxis. The best way to identify risk assessment, I don't have much time to get into this today, but the best way to identify risk of cancer-associated VTE is to use a risk assessment tool. Over the past decade, there have been a bunch of risk assessment tools that have been developed. Some of them have been validated, and some, such as the original Corona score, have been validated in multiple patients, over 50,000 patients at this time. And so guidelines currently recommend risk assessment and of cancer patients initiating systemic therapy, as well as considering risk assessment for cancer patients who are hospitalized. So let's look at prophylaxis and how we can reduce the public health burden of VTE in people with cancer. There are 3 major settings in which prophylaxis has been assessed. Post-surgical, which has the longest history. We now have several decades worth of randomized clinical trials, so many that I can list here, looking at post-operative VTE prevention, both in the immediate post-operative period and in recent years in the extended post-operative period. It's about 4 weeks after diagnosis. Medical inpatient is another important setting. You just heard a comprehensive overview of that, but I'll show you some data specifically related to cancer. And then, although not today's discussion, I want to briefly mention outpatient prophylaxis as well. Let's start with post-surgical, which is the easiest because there have been so many different clinical trials. I show here the extended thromboprophylaxis trials that have occurred or that have been presented over the past decade or so. As you can see, almost all of them favor extended thromboprophylaxis, specifically in cancer patients receiving abdominal or pelvic surgery for cancer. And there have been a ton of observational studies, which also in general, but not completely, are associated with an improvement in a reduction of VTE. As a result of this, in this latest meta-analysis presented by Noel and colleagues in thrombosis research, extended duration of prophylaxis was associated with a significant reduction in incidence of clinical VTE. We're not talking huge numbers here, 1% versus 2%, without a significant increase in clinically relevant bleeding. Rates were 4% and 4.9% respectively. So I think this has been well proven. I think most surgical teams are very strongly aware about the risk of postoperative VTE and are conscientious about immediate postoperative VTE and should have plans in place for extended prophylaxis after surgery as well in people who are at risk for that. What about medical patients? Certainly these form the bulk of inpatient hospitalizations. Here, I'm sorry to report that there continues to be a major knowledge gap. The data for inpatient prophylaxis came to us originally from these 3 trials, Medinox, Prevent, and Artemis, all of which showed a substantial relative and in some studies a substantial absolute risk reduction. But these only included patients with cancer. They were not exclusively cancer-specific trials. There are, in fact, no cancer-specific data. Cancer patients accounted for only 5 to 15% of patients in these studies. And as you can see at the bottom, the subgroup analyses of efficacy were not significant because the subgroups were so small. We also don't have good safety data in this population. So despite recommending inpatient prophylaxis to tens of thousands, if not millions of patients worldwide, this relies on very slender data, really extrapolation of data from acutely ill medical patients. And we don't actually know what the appropriate dose is even of prophylaxis in this setting. Because of these deficiencies in the literature, Jeff Zwicker, I, and our colleagues recently completed a pilot randomized phase 2 trial looking at inpatient prophylaxis in hospitalized cancer patients and asking the question, is fixed dose enoxaparin or fixed dose low molecular weight heparin, which is currently the standard in most US hospitals, the correct standard, or do we need to weight adjust enoxaparin or low molecular weight heparin in this population? Again, this was a pilot trial with a very small sample size, but we did not find an increased risk of major bleeding with weight-adjusted enoxaparin. But we did find that with fixed-dose enoxaparin and screening for DVT, that there continued to be a 22% rate of DVT despite fixed-dose enoxaparin. So I think much as we've learned from the COVID literature, I think it's probably true that cancer patients are at elevated risk compared to acutely ill medical patients. It may be that we need actually a higher dose of low molecular weight heparin to successfully prevent VT in this setting, but that studies remains to be done. There are retrospective data evaluating risk status. So I talked about risk, and that risk applies to cancer patients inpatient as well. These are data from multiple Canadian centers that were reported in a cohort study a couple of years ago. And applying one of the validated risk scores, the Corona score, they found that a bunch of patients were at low risk, some were at intermediate risk, and some were at high risk. And the risk went up even in the inpatient setting, although the score was originally developed for outpatient prediction of VTE. And they found that the optimal cutoff score was 2 or higher, and the VT rate in that population was about 4.5%. And prophylaxis was especially helpful in the high-risk population as opposed to the low or intermediate risk population. Again, these are retrospective data. Also important to note that outpatient prophylaxis can also prevent VT from happening because you can prevent VT before and after hospitalization. There have been a large number of clinical trials that have been done, including low molecular weight heparins, and most recently 2 studies in high-risk patients with DOACs, AVERT with apixaban, and Cassini with rivaroxaban. Since today's focus is on hospitalized patients, I won't go into the details of these 2 clinical trials, but just point out that there's now one of many meta-analyses and systematic reviews have been presented. This one took about all the trials that were done with risk assessment of information available. And these total about 4,600 ambulatory cancer patients that were starting systemic therapy with a Corona score of 2 or higher. These patients across these trials were randomized to either DOACs or low molecular weight heparins versus either placebo or standard of care. And as you can see, about 2,800 patients had a score of 2 or higher. And the risk reduction in this population was about 0.58 for VTE, whereas for 3 or higher, it was even better, 0.45 for VTE. What this translates into in terms of numbers needed to treat is quite meaningful for cancer patients. So it's around 25 or so for patients with a score of 2 or higher, around 17 or so for patients with a score of 3 or higher. No major concerns about the number needed to harm, and no increase in mortality. If anything, outpatient prophylaxis seemed to favor mortality, although these trials were not designed to study mortality and therefore were not powered for it. As a consequence, guidelines now recommend both inpatient and outpatient prophylaxis. I've shown you 2 of the major guidelines here, ASCO and the ITAC guidelines, both of which recommend that cancer patients who are hospitalized should receive VT prophylaxis and provide a list of agents with which this can be determined. In 2021, what can clinicians and health systems do? Because this is really responsibility not just of individual clinicians, but also of health systems as well. I think first and foremost is that cancer patients remain woefully unaware that they're at risk for DVT or PE. About half of cancer patients actually don't know the warning signs of DVT or PE and don't know that they're at risk for it when they're on chemotherapy. So we must educate patients both as individual clinicians and as health systems. We should have literature available. Individual clinicians should assess the risk for VTE and bleeding. Health systems should create risk assessment programs. There are formal risk assessment tools that are available that can use electronic medical records to assess risk. And individual clinicians should consider prophylaxis in the appropriate settings for the individual patients. Health systems should create infrastructures, digital infrastructures to offer prophylaxis to at-risk patients. So to summarize, cancer-associated thrombosis remains a big clinical problem with an unacceptably high burden. It's prevalent with even newer treatment regimens, including immune checkpoint inhibitors, and is associated with bad outcomes for cancer patients, including association with mortality, increased risk of hospitalization, and increased duration of hospitalization. We've made a lot of progress in the past decade. I'm very proud of all the work that's been done. We have an improved understanding of risk. We have new options for primary prevention. We have new options for treatment. And we have implementation science approaches using electronic medical record tools to translate the results of trials to benefit for patients. But we also need a lot of work, and we need your help to make all of these different trials that have been conducted, to translate them into benefit for individual cancer patients if we are to reduce the public health burden of VTE in cancer. Thank you very much for your attention.
Thank you so much, Professor Khurana. So without any delay, I would like to introduce our final speaker, who's Professor Beverly Hunt, who will look at special cases of thrombosis and thromboprophylaxis. As you may know, Professor Hunt is the chair of the World Thrombosis Day Steering Committee and a consultant at Guy's and St Thomas's Hospital in London, and a professor of thrombosis and hemostasis at King's College in London. We look forward to your presentation, Professor Hunt. Thank you.
Well, thank you very much. I'm actually sitting in my office in London, and you can see it there on the slide. I'm in the White Building on the right, looking out over the Houses of Parliament. It's not quite such a sunny day today. So every patient is special, and I'm picking on the two groups of patients that are the biggest of the residual patients that haven't been discussed, and that's the surgical patients and the obstetric patients. I have no disclosures. I take no money from Big Pharma. So our learning objectives are to understand what we're doing with thromboprophylaxis in surgery and obstetrics, and the evidence base that supports what we're doing. So we're talking about hospital-acquired thrombosis. In this term, we call it HAT. And for thrombosis, we really are talking about venous thromboembolism. It remains the #1 global patient safety issue, and the WHO estimate that there are 10 million cases of hospital-associated VTE every year. By far the biggest consequence of admission to hospital when you compare it with infection. And we define hospital-associated VTE as VTE occurring within hospital and up to 90 days post-discharge. It's clearly underdiagnosed, we know. Now, if we look at the surgical patients, they account for 25% of hospital-associated VTE. Medical patients account for the biggest group. And pregnancy is a sizable cause because we know pregnancy is a prothrombotic state. And when we look at pregnancy, 1 in 1,000 women will have a VTE during their pregnancy or postpartum. So let's look at the hard data that we have for rates of VTE after surgery. This is a fantastic study in the UK. They looked at 1 million women, and they looked at the women who had surgery and the rates of VTE afterwards. And you can see the risk is greatest for the first 3 weeks and gradually falls off and comes back to near normal by 10 to 12 weeks. And the risk of pulmonary embolism is considerable. When we look at pregnancy, we know as soon as a woman is pregnant, we have increased risk of VTE, but actually the biggest risk is postpartum. And half of the VTE occur in the first 6 weeks in the postpartum period. But goodness, there are so many factors that will also increase the risk of VTE. So in developed countries, women are getting pregnant at much older ages. Age is a risk. We have the pandemic of obesity in the UK. The average BMI is 28. It's the same in pregnancy, and it's increasing the risk of VTE. And so we go on down the list. We know that some of the bad outcomes in pregnancy are also associated with increased risk, including obstetric hemorrhage. And then we keep finding new causes of increased risk. So one of the most recent ones is finding that if you have in vitro fertilization, your risk of VTE is increased all the way through pregnancy. Quite can't understand how this is the pathogenesis of this, but this is the reality. So we have this British data looking at women who have been admitted to hospital during pregnancy or the puerperium and their risk of VTE over the next few weeks. You can see the pattern is much the same as after surgery. So we've got increased risk for the first few weeks, falling off. And this Californian study took the period of risk out further, right out, and showed us that really up to 12 weeks postpartum, we still had an increased risk. So very similar to surgery. So let's now look at VTE risk assessment. And in surgery, we have established VTE risk assessment tools, perhaps the most famous, named after Joe Caprini, as the Caprini score, highly validated, tested in many. In the UK, we have a risk assessment tool called the NHS England tool. And by using that, we have reduced the death rate due to VTE, but it hasn't been properly validated in randomized controlled trials. There are many others. Pregnancy is a different matter. So like all the other risk assessment tools, people thought about what are the risk factors that they knew of in pregnancy, and they devised scores. So this is the Royal College of Obstetricians VTE risk assessment tool, lots of risk factors, and we have to, in pregnancy, manage risk according to the period of pregnancy. So every time the patient comes up to the clinic, they should have a VTE risk assessment to see whether they might need intervention with thromboprophylaxis. I think there's general agreement that those women who get admitted to hospital should probably all receive some form of thromboprophylaxis if they don't have increased bleeding risk. And this is the Swedish risk assessment tool. They are scoring slightly differently from the Royal College of Obstetricians, but they're adding up the score and deciding whether to give thromboprophylaxis based on that. So let's look at the evidence for delivering thromboprophylaxis. And I think the surgeons should be amazingly proud of themselves. They started off the whole thinking around thromboprophylaxis. Look at those first studies back in 1975. KCAR did a study where they gave unfractionated heparin versus placebo to surgical patients, and they reduced the rate of fatal PE. Claggett did the same 10 years later, and Collins did the same in orthopedic patients. So we have had the evidence for decades now that thromboprophylaxis in surgical patients reduces death due to pulmonary embolism. Not only that, but they delivered as well on extended thromboprophylaxis, by which I mean extending out post-discharge. These are studies from hip and knee replacement. If you just give in-hospital thromboprophylaxis, you reduce rates. If you give for longer, then you reduce the rate of VT further, and the increase in bleeding was tiny. But the surgeons have been amazing, actually, because when we look at how they practice, their practice has changed dramatically over the last 30 or 40 years. I can remember when I started out, if we did a hip replacement as an orthopedic doctor, we put the patients to bed for 10 days and asked them not to move. Nowadays, that must have been giving incredibly high rates of PE. Nowadays, they have a hip replacement, they are up later in the day and mobilizing and will be home by day 5 instead of spending 10 days immobile with a catheter in a bed. And also they have improved the anesthetics, they have improved hydrating the patient. So if you look at all the trials of thromboprophylaxis over the last years, back from 1950, and this is looking at over 6 million patients, the actual background rate of VTE has fallen dramatically. So the surgeons and the anaesthetists are really helping reduce rates of VTE. So we also have to consider with surgery that some patients bleed, and they bleed after surgery, and the surgeons have done a lot of work looking at mechanical thromboprophylaxis. So this is a meta-analysis looking at all the trials of those who got intermittent pneumatic compression compared with pharmacological thromboprophylaxis, and clearly we don't have the bleeding problem with pharmacological IPC compared with pharmacological thromboprophylaxis. Not only that, but if you use intermittent pneumatic compression well, then the benefit from it is similar to pharmacological thromboprophylaxis, as you can see from this forest plot. However, there is some concern these days about anti-embolic stockings. So there has been very poor data on the benefits of anti-embolic stockings over the last few years. As a nation, NHS England spends £65 million a year on stockings, which is about $50 million. Should we really be using stockings when they have shown such poor efficacy? So in the UK, we have been funded to run this big study, a randomized controlled trial, looking at stockings in the context of moderate risk patients who underwent surgery. So they all got low molecular weight heparin, and then they got stocking or no stocking, and the result showed no benefit in clinical outcome whether they received stocking or no stocking. And we just have been funded to do a further study to look at those low-risk patients who would normally only give stockings to, and we're going to compare stockings versus no stockings. Really exciting times. So let's have a look at all the randomized controlled trials of thromboprophylaxis in hospitalized pregnant women. Oh, well, there aren't any, nothing. And the issue has been, it's so difficult to do trials of anticoagulation in hospitalized pregnant women, because we still know they have quite a low rate of VTE. You'd have to have vast studies, and no one wants to not give these women some form of thromboprophylaxis if they're at risk. So it's an extremely difficult area to do randomized controlled trials. So we have been giving quite a lot of thromboprophylaxis in the UK to all our women who have what we consider to be risk factors for VTE, and yet we do a post-mortem on all of our women who die. And even now in 2021, we have a continuous number of deaths due to VTE, similar numbers to this 212 to 214 data collection. VTE remains a major cause of maternal death despite the use of thromboprophylaxis. Are we picking up the right risk factors? So if we look at thromboprophylaxis, we know from the guidance, which summarizes all the data, that in surgery, we have a glorious wealth of data. And so we have these fabulous ASH guidance, which can compare the utility of just using aspirin after hip replacement with the use of low molecular weight heparin and the direct oral anticoagulants. And we know really to the number what the size of the benefit is. And we know that if we give thromboprophylaxis, we're reducing mortality considerably and the rates of symptomatic PE and DVT, although there is a risk with major bleeding. And this actually shows that aspirin has some benefit, although not quite as much as anticoagulation. We also know that if we use extended thromboprophylaxis in at-risk groups, so this is hip and knee replacement, cancer surgery, we also know the size of the benefit and the increased rate of major bleeding. So we have done wonderful work over the years in surgery. Of course, we need some more studies in certain areas. Areas such as vascular surgery could still do with a few more trials, but overall, we have got a massive amount of data. Now let's look at pregnancy. Well, we have to start looking at pregnancy knowing that we can really only use heparin in pregnant women because the other drugs will cross the placenta and cause problems. So the heparinoids are the ones we use, and we tend to prescribe thromboprophylaxis once a day. We don't tend to use any monitoring because low molecular weight heparins have got predictable pharmacokinetics, and most guidance will advise giving weight-adjusted low molecular weight heparin on virtually no evidence. But we do have this problem with obesity. We do have some very large women, and we feel it is appropriate. But all the time I'm talking, I'm saying we feel rather than we have the evidence base to support this approach. And then we have quite complex guidance telling us what to do for pregnant women based on risk, but not evidence based on trials. And we would tend to give any woman who didn't have a bleeding risk, who was admitted to hospital during pregnancy or puerperium, low molecular weight heparin. So just to finish off, to say that if we do apply VT risk assessment and mandate it in a country such as NHS England, we will see, if a thromboprophylaxis is applied, a fall in death rate due to hospital-associated VTE. And this is the rate of VTE deaths after and during admission in NHS England since we applied a mandated system back in 2012. Not only that, just to remind you how cost-effective thromboprophylaxis is, by reducing the rate of VTE, we do not have to treat, we do not have to do CTPA and Doppler ultrasound and put patients through months of anticoagulation. So it's highly cost-effective. So to conclude on my special patients, surgery is a wonderful area where thromboprophylaxis is an art form. It's effective, it's safe. We know doses of drugs to use. We have the option of intermittent pneumatic compression. I suspect anti-embolic stockings will gradually fall out of favor because they lack utility. And the excitement really is around the new agents coming through. We have done low molecular weight heparin to extraordinary lengths. We need to find a drug that is as effective or more effective without an increased bleeding rate. That is the holy grail of looking at anticoagulants, and they will be tested out first in surgery. So excitement to come. Pregnancy needs more work. We know we need to help women. We know we need to give thromboprophylaxis. It is safe, but trials are difficult to do in the UK. We're about to assess whether we can start doing them, and we need more data on VT risk assessment and thromboprophylaxis in pregnant women. Thank you very much.
Thank you very much, Professor Hunt, for a wonderful talk. So now we do have a short time for questions with the speakers, and I've had a few questions come through. And I thought I might start with a question that I might start by directing to you, Professor Paropoulos. How long should we continue DOACs post-discharge in patients with COVID-19?
The best data, both in medical patients, sepsis, pneumonia, but now in the COVID era, suggests about 30 days. Most of the events occur within these 30 days, although there are events after 30 days, but you'll probably get the best benefit within the 30-day time frame after discharge.
Okay, thank you. Anyone else have any, Professor Hunt, Professor Khurana, would you agree?
Yep, we agree.
Cool. And then a question directed at you, Professor Khurana. When a cancer patient develops a VTE, how long do we have to wait before restarting chemotherapy after the diagnosis and treatment?
Yeah, that's a great question. I didn't have a chance to address treatment or secondary prophylaxis today, but obviously with a new diagnosis of acute VTE, you want to treat the patient as soon as possible. There's really no contraindication to resuming chemotherapy as long as the patient's hemodynamically stable and healthy and out of the hospital. I would not do it for somebody who's hospitalized, but once they're out of the hospital and doing better, there's no contraindication. Anticoagulation is not a contraindication to chemotherapy.
Thank you. And I think this might be up your alley, Professor Hunt. So it deals with the issue with mechanical thromboprophylaxis. So do you feel that using mechanical thromboprophylaxis alongside pharmaceutical thromboprophylaxis might make a major difference in preventing VTE, especially in the COVID-19 population?
So that's such a great question. And we know in the critical care setting that mechanical thromboprophylaxis may or may not have additive value outside of COVID. Really, we could benefit from a trial of intermittent pneumatic compression. I think with COVID, it is an extraordinary condition. We do have very sticky blood, but we've also got endothelial cell activation because COVID is causing that. So a lot of the risk is coming through the sticky blood. And so I'm not sure how much intermittent pneumatic compression will help, but it would be a fabulous trial to do.
Thank you. Well, look, I think we now have gone slightly over time. I really would like to thank all of the participants for joining us on this World Thrombosis Day webinar, and special thanks also to the speakers, Professor Hunt, Professor Khurana, Professor Paropoulos, but also to the ISTH and also the CDC for their support with this webinar. I hope you all have a wonderful day and celebrate World Thrombosis Day in some wonderful way. Thank you very much, everyone.